I'd like to start by acknowledging the traditional country that we're on, the Wiradjuri people of the Kulin Nation, and pay my respects to traditional owners past, present, and because I'm a midwife, for the future. And I went to the Melbourne Museum yesterday because the weather here was so gorgeous outside. One had to go somewhere indoors. And it's 2,000 generations of Aboriginal people who've been giving birth and growing their babies on this country, probably not far away from where we're sitting today. And I think it's always important to remember the resilience and heritage that we're so fortunate in Australia to have. So today I'm going to take probably 40 odd minutes, maybe a bit shorter, and romp through kind of maternal health, my view of the world in terms of why maternal and child health matters. Some of the big challenges, and they'll be very familiar with from all of you, I'm sure. Some of the wins. I do sometimes think we talk about it and get ourselves very depressed that it's all too hard and it's all too difficult and we're never going to get it better. Well, there are some wins and we have to celebrate those. And I think this is the moment for opportunities and we need to harness them and embrace them. So this slide, many of you will be very familiar with. Is there really a problem? So 6 jumbo jets go down, or 3 big jumbo jets go down every day across the world in terms of global maternal mortality. 300,000 women still die each year because of pregnancy-related causes. And while that's come down about 40% since 1990, that's still an enormous amount of women who die. Almost all of them are in low and middle income countries. Almost all of them are preventable. Many of them are young women, are adolescents. Many did not want to be pregnant. And 27 million women suffer morbidity. So while maternal mortality is the tip of the iceberg, and it's a really nice measure of what's going on in a health system and the fragility or non-fragility of a health system, there's this enormous iceberg underneath. And the recent estimates from the Maternal Health series in The Lancet puts it at a pretty big number. And an even bigger number of women who want to avoid pregnancy but do not have access to safe and effective family planning or modern contraceptives. So there's an enormous need out there. And 2.6 million women have a stillbirth each year. So 2.6 million women go home from or leave their childbearing experience without a baby in their arms. And we still have many, many under 5 deaths, many of them occurring in the neonatal period. So the day you're born is the most dangerous day in your life, many people say. We need to get women over the day they're born. So this is the reality for many women around the world. Less than half, fortunately, give birth outside a facility. And this is from a colleague of mine, Lisa Vallely, in Papua New Guinea, with her permission. This is a river, as you can see, the river that's lost its water. There's someone walking along here. And here there's a little collection where somebody has gone to give birth. And the woman who gives birth outside a facility, many women give birth in a hut or in someone's house, or maybe not in a facility or something that's formal. It's rare for women to give birth in a field like this, but it happens. And then whether you're in a facility or in a home or out in the wilds, babies get given water, babies get their cords cut in an unsafe way, babies are cold, this baby's on wet grass or wet reeds. So you can see why 45% of under 5 deaths occur in the neonatal period. This is another reality. This is a woman in Bangladesh. And if you have a close look at this photograph, it's pretty grim, really, but many, many women around the world give birth like this. The bed doesn't have any sheets on it. Under here, I had to crop the photo, but there's a red blood stain that could be blood, could be something else. This doesn't look like it was ever cleaned. There's a drip stand. Maybe she should have had a drip. Maybe something should have been up there, but it's not. So not a really warm and embracing way to bring your new baby into the world. And she's alone. She doesn't have a health worker with her. She doesn't have her mother or her sister or a support person. This is becoming more common, this sort of a labour ward. This is in the hills of Timor-Leste. The women have got the drips up. They may or may not need them. They're on a bed, doesn't have any blankets or sheets at all. There is oxygen, so there's some equipment. There is a clock that's kind of helpful around childbirth. There's not a lot of privacy, not a lot of dignity, and again, no support. And there is a health worker, probably a midwife. And in many parts of the world, the midwives are not very kind to women who give birth. They yell at them or slap them, or they're not very generous. There is disrespect and abuse. So increasingly in the health system strengthening, we're encouraging women to go into facilities to give birth. Then we don't treat them very nicely, and we wonder why they have their next baby, hopefully not by the river, but somewhere that's not a health facility. And again, this is the reality for many families around the world. These are 4 babies from the same family, all under 5, all died within a decade. And I can't imagine what it would be like in our country if we went to a graveyard and found 4 babies in contemporary Australia who had died very young. So I'm going to show you a few maps. Some people have seen these maps before, but I think they sort of show the maternal health issue in a very quick way. These are from World Mapper, and you can go online and get all sorts of maps from worldmapper.org. This is resizing the world according to the population. So this is the total population, and it's resized according to the area density. So you can see most people live in India and in China. We're a bit tiny down here, but Indonesia's kind of big, and relative to land mass, somewhere like Japan is very big. So it looks different to what it normally looks like. This is where babies are born, so a little bit in line with where people live, although less babies are born in Japan than the Japanese would like. Still lots of babies are born in this part of Asia. In China, starting to get more babies as the one-child policy has been relaxed. And quite a lot of babies born in Africa. This is who spends money on healthcare, which is a very different picture. Africa almost disappears, and even these countries in Asia that we saw before were quite big in terms of where women give birth have vanished a little bit. And this is where women die in childbirth. So not a straight line correlation between where healthcare is spent, but certainly you can see the disparities around the world about where babies die. So maternal mortality is still very high in many parts of the world, increasing, including in our region, which is here, 300 to 499, and then getting higher across Africa and higher in parts of Asia that we align ourselves with. As I said, MMR is a very good indicator of the functionality of the health system. If you have a high maternal mortality ratio, it's likely you don't have a very functional health system. The exception to that, which possibly isn't an exception, is the US, which in many parts of the US, the maternal mortality is the only developed country or high-income country in the world where the rates are going up. But again, that does reflect a dysfunctional health system, amongst other things. There are many things that have gone well in terms of MMR. Overall, the maternal mortality rate has reduced by 44% globally. But you can see here, the countries with the highest MMR have remained remarkably high, coming down a little bit here, but still, this is in the around 800s per 100,000 live births. In Australia, the MMR is 8. That gives you a sense of the magnitude of difference. These are the lowest, the 10 lowest MMR countries, barely registering along the bottom. We wouldn't be in the 10 lowest, but we're kind of in the next level up. And this number in this graph line in the middle is the ratio between the highest to the lowest, which is actually getting bigger. So the disparities or the inequities are increasing even if the overall rates are going down slowly. So we still have a very big problem to address. Why does it matter when a mother dies? And in global context, when a mother dies, the infant is much more likely to die than survive. The health of the children generally are likely to be far worse than those of mothers who don't die. And sadly, children whose mothers die are more likely to be abused, given chores that means they can't go to school, made to do hard labour, and sexual abuse of orphan children by family members is frequent. So if you're a child and your mother dies, you're in trouble. You need help. This has an ongoing impact on the community. You can imagine in a family, someone needs to look after that child, someone needs to take on that little family that now is motherless. And that may be a family at a wider level who's also unwell, particularly in an HIV context. And then we have an impact on the community and the economy. These are children who will not grow up to make a living or to earn productively for the country. So this is when it all sounds too hard and it's all terrible. But it's good to know that there are improvements. At a global level, there are improvements, not as fast as we would like, but they are happening. And then at a local level, different countries are making progress. So this is some data that I was involved with the Lancet series in Midwifery a couple of years ago, where we looked at the 10 countries that had actually showed a reduction in the time period. So over 2 decades, who had shown a reduction? And some of them are sharper curves, sharper lines. Some of them are a bit slower, these ones here, but they're all heading in the right direction. So we looked at who's making improvements, and then we looked at why, and picked out 4 of these countries to do an in-depth case study on why and how were they making a difference, to try and then help the 10 countries with the least rapid increase or reductions. So this is hard, I know, to read, but just to tell you that you have to have multiple interventions on multiple levels. One intervention will not address maternal mortality. This is an example from Morocco, where they looked at political leadership, made aid sensitive to maternal and newborn health priorities, undertook strategic and resource mobilisation, making money go to where it was needed, having access and uptake, and especially increasing the numbers of midwives or health workers who provided maternal and newborn health services, removing barriers to access, ensuring that facilities were close to where communities lived. Then they scaled up coverage. So it's all right to have some access, but you now need to make sure everybody can get there, and we have universal coverage. So things like backup and referral were addressed. And then this top line is the outcomes. And this is to show that it's multi-layered and not just single interventions, and that we need government and we need the international community, and everything has to sort of be coalesced together rather than just pocket interventions. We also then looked at what are the patterning in the sequencing of health system strengthening efforts. So what were people doing commonly in the same sort of order since the early 1990s? And each one of these is a different time frame, but it shows the importance of each one of these factors. The first one is revitalisation and expansion of the service network. So having a health model that's based in the districts as well as based in the centre, ensuring that health services can be accessed for all. Investing in midwives is a key point in each of these countries, come to at different stages. Indonesia's the earliest, from the late 1980s, invested in primary level 1 or 2 year trained midwives, made them all go out into the community, and subsequently has been upscaling them to being higher qualified. Removing financial barriers happens in the part of the sequencing, again at different time frames for each of these countries, but it's incredibly important. And then quality of care. Quality of care is now the thing we need to focus on. In previous years, we've just focused on increasing the workforce. Lots of midwives, lots of doctors, lots of community health workers will bring the MMR down from the high numbers to about 150, 200, something like that. If you want to get from 150 to 70, which is the Sustainable Development Goals, you need quality care. It's not just more of the same. It's not just more ordinary workers who don't have access to facilities. So each of these countries had a similar sequence, even though it happened at different time points. This is the other piece of work we did in the Lancet series, was developing what is quality care, and I'm going to take through this framework very briefly, just to explain the different elements of quality care. At the top, there are the things that most research, most development is done on. This is education, information, health promotion, the screening and assessment that we do, the promotion of normality and the prevention of complications. So much of the work that we do in maternal health is focused in these areas. They're critically important, but they're not the only part of a whole quality care system. But there have been what we've spent a lot of time focusing on. As well as these other on the top line: managing complications, postpartum hemorrhage, preeclampsia, sepsis, and safe abortion complications or unsafe abortion complications, and access to medical and obstetric and neonatal services. So these are at the top. They have to happen. You can't have anything like a quality service if you don't have these. But we showed from looking at hundreds of reviews and individual papers that we actually need care that's organised. So it needs to be available, accessible, acceptable and of quality to the people it's being served and also to the providers. You need a competent workforce. People need continuity. Women need continuity in all contexts, but particularly when they're having a baby. And services need to be integrated. So there's a level of organisation that needs to happen within a system. The next aspect is values. Respect. I mentioned the lack of respectful care in the beginning. Women deserve and need respect when they're pregnant and giving birth. They need effective communication. We need to understand their communities and their understandings and tailor care to their needs, not just a menu kind of approach. We then need philosophy of care. So this is optimising what women bring to the table in terms of childbearing. Women are not empty vessels that need to be filled up necessarily. They come with lots of community knowledge, their own knowledge from previous experiences from their families. We need to build on that, not disregard it, and strengthen their own capabilities. And this involves working with the community to strengthen their capabilities. And only using interventions when required. There's a real problem at the moment in many low to middle income countries of excessive interventions with many unintended consequences, which need to be addressed. And finally, at the bottom, the care providers. And this is where, as Freya says, I've spent most of my career focusing on having providers who have skills and competence and who can work together effectively in teams and manage consultation and referral across the continuum. So this is a really neat model. The challenge is how to implement it, and even more challenging, how to measure it. How to measure some of these things in a meaningful way that will make a difference and drive change. So we took that model in the Lancet series of midwifery and just tried to work out if you did manage to implement it all, would it make a difference to saving lives? Because it all looks very nice on paper, but would it actually change what happens to mothers and babies? So we used the LiveSave tool that some of you will be familiar with, and took 78 countries, the highest burden, low income, middle income countries that account for almost all maternal and newborn deaths. And we used the Human Development Index to split them into 3 groups of countries: the very low, the medium to low, and the medium. And then applied this model to see whether in example countries whether you'd make a difference. So I won't go through the methodology, it's in the paper, but we looked at including average mortality rates and ratios, health intervention coverage, HIV prevalence, contraceptive prevalence, and fertility rates, and designed sort of hypothetical baseline populations for those 3 groups of countries. The interventions are the ones in the essential interventions for reproductive, maternal, and newborn child health that some of you will be familiar with, and also the ones that we identified in that framework that I just showed you. We were particularly interested in what could be delivered by midwives. If you had well-educated, well-supported, well-regulated midwives in a functional system, what would your capacity of that be? What difference could you make? And then you also need specialists on top of that. So we need access to caesarean section, blood transfusion, and other medical interventions. So we developed 4 scenarios. The first one was if nothing changed. The second one was if you increased quality maternal newborn health by only 10% in a country. Not very much, just a little bit more. Would it make a difference? Then we looked at a bit more, 25%, and then universal. If everybody who could, and we did 95 because we recognised not everybody would, but if everybody could access the services, they were readily available, the staff were there, what would happen? And then we did an attrition going backwards, because some countries have shown that they're going backwards. So it's important to kind of think, what's going to happen to those countries? Unsurprisingly, if you increase services, you'll decrease deaths. But we wanted to kind of quantify what would that mean. And I'll just show you the graph because it's probably easier to show. So blue is the lowest of the countries, so the lowest Human Development Index countries. And even with only a 10% increase in access to those services, to the midwifery framework or the maternal newborn health framework, you would reduce deaths. And even if in the moderate to high Human Development Index of those 78 countries. So even at a small level, you make a difference. If you get it up by 25%, you make a big difference to deaths. And up to 95%, an enormous difference to deaths. Of course, this is a bit Pollyanna-ish. There's a whole lot of other things to be thought about, but it was to try and increase the policy dialogue as if you can actually make a difference. It's not too hard. Because if you go backwards, your death rates are going to go up. So this is part of the story around why we need quality maternal and newborn health services. So it's all very well knowing what we have to do. We've got the interventions, we've got good health services, we've got all the things in place, but do we have any providers? Do we have enough providers who are actually able to deliver this service at scale? Not in one tiny little hospital, not just at the big district hospital on the hill, but at scale for everybody. So this is another piece of work that I've been involved in, the State of the World's Midwifery from 2014. We're just about to start State of the World's Midwifery for 2020, which will be collecting data in 2019 from hopefully 75 countries, which are the 75 to 78, the lowest countries in the Human Development Index. In 2014, we chose 73 countries who accounted for most global maternal and newborn deaths and stillbirths, and found that they only had less than half of the workforce. So they've got most deaths, but not enough workforce. We surveyed each one of these 73 countries using a quantitative data collection tool about their workforce, looked at mortality rates, fertility rates, population expansion, and then also information about their cadre, how they were educated, how they were trained, and tried to calculate met need. So on a couple of different scenarios, do they have enough of the workforce to meet their need in their country? Only 4 of the 73 countries had a midwifery workforce that was able to meet the need, that was able to deliver the essential interventions for sexual, reproductive, maternal and newborn health. And this includes midwives, doctors and regulated community health workers, not TBAs, village birth attendants, village health workers. So the sort of professionalised workforce. And the 4 countries who did were Azerbaijan, Peru, Brazil, and I've forgotten the last one, but they're all at the top of the middle income category. Most countries were well down, and some countries down to sort of 15% of the workforce to meet the met need. In our region, Papua New Guinea and Solomon Islands were the only 2 countries included in this analysis, and they're at about the 40% mark. So they do not have the amount of workforce to meet the number of pregnancies, the number of births, the number of women who require contraception, and the number of babies who require care. And part of that analysis was looking at, well, who can deliver the essential interventions? And we showed that midwives who are educated and regulated to international standards can provide 87% of the care needed for women and newborns. So these are the people you need to train, as well as the other cadre who need to work alongside them. But we can't, what's happened in some countries is midwives have been trained, educated, sent out into the villages and the communities with no equipment, with no telephone, with no resources, and no way to refer anybody, and the maternal mortality and other rates have not gone up, and people have said, see, it doesn't work. So you can't send these people out in isolation. They need facilities that function. They need safe blood, access to caesarean sections, access to newborn resuscitation within a functional health system, of course. So we've just recently, or last year, repeated this analysis simply in the Pacific region, and we're currently now working with UNFPA, and I'm working with them to look at a more detailed analysis of the 15 Pacific Island nations, including Papua New Guinea and Solomon Islands, again, to try and increase the policy dialogue about developing the health workforce. These are the countries we looked at, and these are the midwives per 1,000 population. It's difficult in the small island nations to work out what the population should be of midwives because the population is so small. So Niue has 2 midwives and Tokelau has 4. So Tokelau looks like it's doing really well, but if one of those midwives goes on maternity leave or retires, and most of them are at the retiring end rather than the maternity leave end, they're in big trouble. PNG has about 800 midwives at the moment, regulated. Fiji has about 350. They're not enough. The number that should be is probably somewhere between 4 and 6. And so none of our countries in the region get anywhere near that. You can imagine the challenges for many of these countries. How do you train a workforce when you've got to send them all away? How do you get them to come back when they've been sent away? Often the temptation is to stay or not to go back. And then how do you not enable people to develop capacity and go and do other things? That's a kind of a common human thing that we all do. So this is a very big challenge, and the heads of health across the Pacific, we presented this data to them last year, and we'll be presenting again to them next year at the next meeting to try and develop some interest in strengthening workforce capacity across the Pacific. So it's pretty clear you can't have health without a health workforce, and you certainly can't have reproductive, sexual, maternal and newborn health without a workforce who can look after those things. And that may not be a generic health workforce. So I want to move on to some opportunities now in the next sort of 10 minutes. And I think the SDGs, while they're potentially a bit of rhetoric, they're an opportunity for us. All countries, all 193 countries, I think, have signed up for these. The Millennium Development Goals were very focused on low to middle income countries. The SDGs are much broader, and all countries have signed up for them. And I think we need to use the bits in there that we can in all of our work here at the Burnet to ensure that we can address those goals. Many of us were a bit sad. We only ended up with 1 goal out of the 17. In the MDGs, we had 3 or 4. But I think they're all interlinked. And I'm just going to show you how I think they're interlinked. So if we take maternal and child health, the SDG goal is for a maternal mortality ratio of no more than 70 per 100,000 live births by 2030. That's a big number for some countries. It's a little number for us, but it's a big number for some of our neighbours. To get there, we're going to have no poverty. We can't have families who cannot afford to feed their children and who are then malnourished, and their children are malnourished and start off the stunting trajectory right when they're born. They have to be able to eat. We have to have quality education. And over again, it's been shown that one of the key drivers to reducing maternal mortality is education for girls. If you educate girls, you're much more likely to reduce MMR. Gender equality. And again, very obvious, particularly in this region and in our neighbouring countries, of the absolute importance of gender equality. Clean water and sanitation. Many places that you go or you work in or you know about do not have clean water and sanitation. Something like 40% of places where women give birth in Papua New Guinea do not always have running water or always have electricity. Reduced inequalities, that graph I showed you of the difference between the highest MMR and the lowest MMR needs to come closer. We need to work on bringing up the most poor, the most disadvantaged, the most vulnerable. And climate action, particularly in our part of the world, where the water level's going up and damaging many roads, so access is going to be more difficult in many small island Pacific nations, and the increasing weather changes, tsunamis, cyclones. So there are only a few of the SDGs, but I think there's a link for everything, and we need to harness that link. So I think these next few slides are about what I think good maternal and child health needs. And it's not only access to midwives. We need to address gender-based violence. In our region, the rates of gender-based violence are extreme and terrifying. And worldwide, it's 1 in 3. But in countries like Papua New Guinea, Vanuatu, Solomons, it's much higher than that. And the work that all of us do needs to address this in the different ways that we can. Mental health is increasingly being seen as a very important area to concentrate on. In Australia, death due to suicide in the postpartum period is one of the highest reasons for maternal mortality. And that's probably not dissimilar to many other countries. We just happen to measure it at the moment, but many places don't. So poor mental health, particularly in the during pregnancy and the early postpartum period, is critical. We have to focus on girls because good maternal and child health relies on us knowing how to sort out girls now and looking after them now. What the world will look like in 15 years depends on what we do with 10-year-old girls today. And so we, in our world here, we cannot address all of these issues, but we need to advocate and support and engage to ensure that child health, adolescent health, particularly young girls, are addressed. About half of the world's 10-year-old girls are now in Asia and the Pacific region. That's an enormous potential. But globally, 32 million girls of school age are not in school. And it's been shown that countries with policies and institutions that can build a 10-year-old's human capital will realise the highest economic gains. So those young ones, those of you who have girls, clearly it's working out with ensuring that girls have the best start, and then working with boys to ensure that gender equity, gender equality starts at a very young age. Women need access to modern contraceptions and contraceptives and safe abortion, and we will not have good global maternal and child health without this. Woman cannot be a maternal death if she's not pregnant. So saving women from being pregnant when they didn't want to be pregnant is actually going to save maternal deaths, but it's also going to save child health because those children, when they do come, will be able to be looked after. Women will be in a much better state physically, emotionally, and economically to care for the children. A focus of mine at the moment is on stillbirth. I'm part of a Centre for Research Excellence on Stillbirth in Australia, and it's a very important area. 2.6 million babies are stillborn each year. The work that many of you do here at the Burnet builds on this. Syphilis, malaria, HIV, this is all very important areas that contribute to stillbirth. We know that babies who are little in utero, babies who don't move as they should, and babies who are subjected to emergencies or complications are more likely to be stillborn. And we need respectful care when we can't prevent stillbirths. So there'll always be some stillbirths we cannot prevent. Those women and families need respectful care, mental health support. It's essential around the world that we investigate, classify and report and act on deaths. And actually, even in Australia, we do this very, very poorly. And nationally, There are 8 different ways of doing this, and none of the 8 mob want to talk to each other. So while we can say to other countries, you need to investigate, report, classify your deaths, we actually do it very poorly here. We do this bit a bit better. We register births, stillbirths, maternal deaths and neonatal deaths. But only recently, and certainly in my previous home state, stillbirths were not recognised with a birth certificate, only a death certificate. That has since been changed. But these things seem little, but they're very important in terms of social and emotional well-being. And a lot of the work that you do is involving other comorbidities, and obviously pregnant women get other comorbidities. They get infectious diseases, they get non-communicable diseases. The epidemic of diabetes that is sweeping the world needs to be addressed. It impacts on pregnant women, and then it'll impact on their babies. So often we put midwives and maternal health workers just do the pregnancy stuff and everybody else does the rest. We need to make sure that there's a holistic model so that the rest is incorporated into what women and babies need, even with comorbidities, and better understand the links. And we need newborn resuscitation and care. I've seen far too many births where the babies come out flat, not doing anything, and everyone's just watched to see whether the baby will breathe. And the baby won't breathe unless someone does something if the baby isn't breathing. So teaching newborn resuscitation is critical, and supporting newborn resuscitation. It sounds like a very simple thing, but many babies die because nobody made them take their first breath. And having this baby survive means the next pregnancy is delayed. It reduces the risk of the woman being a maternal death next time round, means this baby will be better fed and is less likely to be stunted. So resuscitating this baby in front of you is critical, but often that gets missed. So how do we measure quality? I said in the beginning, it's really hard to understand how to measure quality care. Some of the work I'm currently doing is looking at that framework that I showed you and try to understand how do we measure, how do we develop and test quality care? How do we put those elements into practice, both in a high resource and low resource setting, and actually make a difference to care? And in high resource settings, we're getting more evidence that models of care make a difference to outcome. So continuity of midwifery care reduces preterm birth rates in high income countries. Could it be the same in a low income country? Could we rearrange the way services are provided to have impacts on physical outcomes, preterm birth as being the most important, and family planning services? And how do we make providers be kinder, more respectful, and provide better services to the community who come? And what measures and indicators should we use? At the moment we have very blunted measures that mostly measure mortality, morbidity, all the things that go wrong. Can we develop some measures of where things go right, where things are working out, particularly around quality care, and flip the thing around? So finally, the opportunities, a focus on equity, and obviously in this place, it's absolutely core business for all of us. So reaching the poorest women with essential antenatal maternal health care, postnatal care, and adequate nutrition. Addressing family planning, and I actually hate the term family planning, particularly around young women, because young women don't think they're in a family, they're just having a boyfriend, and they're not doing much planning. They're just having fun with the boyfriend. So family planning is a term that is absolutely entrenched, but it's actually modern contraception is what women need access to. And we need to address all the comorbidities, and that's the work that many of you are also doing. So linking in malaria, HIV, TB, diabetes, and the other NCDs. As I've also already said, focusing on girls and adolescents, and developing, educating, regulating the health workforce. It's not enough just to educate them once, which is what happens in many places. They get their primary education, they're sent out there, and 15 or 20 years later someone says, have you done an update lately? And they haven't. We need to continually educate people and regulate them to make sure that they are safe. We need more innovative solutions. We need better things than vaccines that require an injection. And poor small babies are subjected to injections. Inhaled oxytocin is another good example. We need better innovations to deliver the interventions that we know will work. Health technologies, everyone has a mobile phone. There must be a better way of delivering services using that in an effective way. Collaborations, and I think that's something that happens really well here and will happen increasingly in future years, bringing people together from different disciplines, from different ways of looking at the world. We must involve end users or consumers, or for me, women, their families and communities, because only when they are engaged will change really happen. If we come and impose stuff that we think is important without engaging the community, we will never be successful. And we have to work in partnership, particularly with policymakers and politicians, development partners, and increasingly the media and social media, because that's where traction happens. And I think especially in Australia at the moment with different funding opportunities. So while there are lots of challenges, and sometimes it seems in the too hard basket, progress has been made and there are more opportunities that come. Some of it is getting the evidence we have into practice and at scale. We know an awful lot, and many of you have been involved in generating the evidence that we now know works. So we now need to take it from a research or a small scale intervention to an at-scale intervention for the whole community. And at the same time develop and test new approaches. We have to get out of our box and talk to other people and other agencies about what are some other ways we could do these things. Because just doing the same won't bring change. Thank you.